exercise that can be sustained for a considerable time, over 10 minutes, is often classified as an aerobic exercise. The implication is that oxygen intake is keeping up with the rate the muscles are using it in their contractions. Exercise that is more vigorous and cannot be sustained, lifting heavy weights, running upstairs, etc., is often called anaerobic, to imply that the oxygen intake is not keeping up with the oxygen needs of the contracting muscles. The muscle burn that often occurs during strenuous and repetitive muscle contractions is due to the accumulation of lactic acid, an end product of glucose metabolism under low oxygen conditions. When this occurs, cessation of the exercise for a few seconds will typically provide immediate relief because the lactic acid enters the bloodstream and is carried to the liver, where it is converted back into pyruvic acid by a reverse glycolysis series of chemical reactions called the Cori cycle that only hepatocytes have the metabolic machinery to perform.
Hi, I'm Mike Shively, and welcome to Introduction to Anatomy and Physiology. Today we're going to continue our discussion of the muscular system. Do any of you have any questions from a previous session? Adam?
While we're talking about muscles, what are some of the dangers of like anabolic steroid use?
You know, the anabolic steroids are a dangerous group of chemicals. That's one of the reasons why that they've been banned, you know, from Olympic competitors and so forth. They have, although they certainly do produce some positive changes as far as muscle size and that sort of thing, they also have some real dangerous implications on the heart, and they cause some changes in the liver that after a period of time and abusing these drugs to a certain degree can cause irreversible changes. And there have been a number of deaths that have been attributed to the use of anabolic steroids. There are some less dangerous anabolic steroids and some more dangerous ones, but anybody who tampers with these, they're walking a fine line health-wise. Today we do want to talk a little bit about the physiology of muscle contraction and talk about some of the major muscle groups. Let's see if we can put things in perspective. I want to go to the overhead camera for a little bit, and I want to write down the word muscle fiber. This term, muscle fiber, means a muscle cell. So muscle fiber is synonymous with muscle cell. Now we have to be very careful about the term fiber because we use it in different contexts to mean different things. You'll recall, for example, we've talked about collagenous fibers and elastic fibers and reticular fibers as some of the extracellular proteins that are found in connective tissue proper, for example. That use of the word fiber is in reference to an extracellular protein. We're talking at the macro molecular level. Here, when we use the term fiber and muscle fiber, we're talking about a muscle cell. We also talk about nerve fibers quite often. Use the word fiber in connection with nerve, and there the implication is an axon or a dendrite, which is a projection from the cell. So I just want to caution you that, some of the words that we use in reference to different anatomical structures, the context may determine the meaning of the word in that particular area. So when we say muscle fiber, we're talking about a muscle cell. And does anyone remember the three kinds of muscle cells that occur? We got three kinds of muscle tissue because we got three different kinds of muscle cells. What are the three kinds? Susan?
Myofiber, myofilament, and what's the other one?
Well, you're working down the hierarchy within a muscle cell, but I'm talking about skeletal muscle cells, smooth muscle cells, and cardiac muscle cells. Remember, we talked about three different kinds, and we said two of them were striated, one of them was voluntary. I know that it's been a while since we talked about those things. Today, I want to really concentrate on skeletal muscle cells, although a lot of the things that we say and talk about today will also be true of the other two kinds of muscle cells as well. So when we say a skeletal muscle cell or a skeletal muscle fiber, we're talking at the cellular level. Now, inside that structure, let's go back to the overhead camera for a moment. Inside that structure, these cells are elongated. You remember they're multinucleated, so we'll allow these circles to represent nuclei. And these nuclei are jammed up against the cell membrane because, along with all of the other regular organelles that are present in the cytoplasm of this cell, there's a contractile organelle, and there's a lot of them. They're jammed in there like sardines. And that's what you were talking about, Susan. The contractile organelles that are found in these cells are elongated soda straw-like organelles in shape. They take up most of the cytoplasmic space. And each one of those elongated structures within that muscle cell is called a myofibril. The definition of this word, myofibril, is contractile organelle. In other words, these are the cellular subparts that actually allow the cells to get shorter. They are the functional organelles of contraction. So in this cytoplasm, we'd still have mitochondria, we'd still have ribosomes, we'd still have endoplasmic reticulum, we still have Golgi complex. All of those kinds of things would be present. In addition to those organelles, we have this specialized organelle for contraction called a myofibril. Adam?
Are the rest of the regular organelles squished up against the side like the nucleus is?
A bunch of those organelles are actually interspersed in between these myofibrils. A lot of mitochondria, for example, that are in between the myofibrils. But quite a few of the other organelles are jammed out near the periphery of the cell, just like the nuclei are. Incidentally, when we talk about a skeletal muscle cell being multinucleated, having several nuclei, think several hundred. Most skeletal muscle cells have several hundred nuclei, so they're not just a little bit multinucleated, they're a lot multinucleated in that respect, in that regard. All right, what I want to do is I want to take one of these myofibrils. Let's go back to the overhead camera for just a second. I want to take one of these myofibrils and I want to enlarge it. So if you will, I'm going to erase the drawing that we've made. I'm going to take one of these skinny soda straws. I'm going to make it larger. So I'll just erase what we had, and I want to just take, and we'll say this is part of one of those myofibrils. So this is one of those contractile organelles. We'll say a myofibril. If we were to take a transmission electron microscope and magnify this thing several thousand times, we could actually see the structure within that. We could actually see how the contractile proteins were arranged. And what we would see within this organelle is we would see some stacks of relatively thick contractile proteins. And there'll be another stack of these thick ones, maybe right here, another stack over here. And those are called thick myofilaments. I'm going to see if I can write this up here. Each one of those black lines is a thick myofilament. The protein that makes up a thick myofilament is primarily the protein that we call myosin. So you've probably heard of myosin. So myosin is the protein in the thick myofilaments. Now, in between these thick myofilaments are some skinny proteins that actually interdigitate or overlap them a little bit. And of course, this would continue at both ends of this structure for a long way, because these myofibrils are extremely elongated organelles. And each one of these is called a thin myofilament. Thin myofilaments are composed primarily of actin, but there are a couple of other proteins present within them. When you get to a class in physiology in your futures, you will learn about troponin and tropomyosin and some other proteins that are present as well. But the main protein, the one that everybody remembers and learns initially, is actin for thin myofilaments and myosin for thick myofilaments. Now these thick and thin myofilaments are not just kind of hovering in space, you know, like so many flying saucers, the way it kind of looks like we've drawn them. There actually are some cross-linking proteins that actually kind of harness these guys together and keep them in a little set, and these guys. Same way with these thin ones, right in their middles are some cross-linking proteins that kind of hook them all together. Now the reason I'm drawing this is, for one, I want you to realize that it's these thick and thin myofilaments that actually give us the alternate light and dark striping or striations that are characteristic of skeletal muscle cells and cardiac muscle cells. Because where we have a stack of thick myofilaments, like here, here, at either end and here in the center, we have a dark stripe across this organelle. And it makes the dark of the two stripes, alternate dark, light, remember. And then in between, basically from here over to here, kind of in between the stacks of thick ones, where there are only the central sections of some thin ones, we have the light striping. Now, to a histologist looking at a photomicrograph of this organelle, they call the dark stripes A bands, and the light stripes they call I bands. So it alternates dark, light, as we continue up and down the length. When contraction occurs, there are some electrochemical changes on the surface of these thick and thin myofilaments that cause them to slide together or interdigitate. If you can just look up here and take a look at my fingers, if you imagine they're overlapped just a little bit at their ends, the thick and thin ones. And by interdigitate, I mean they physically slide together, as, you know, like you could take the tines of two forks and slide them together. And when they physically all slide together, the total length of this myofibril gets shorter. And when all of the myofibrils within this particular muscle cell do that at the same time, the whole muscle cell gets shorter. And what do we call that?
Contraction.
Contraction. So the point that I want to make with this illustration is that what we call contraction, or the shortening of a muscle, down at the cellular level and at the clear down to subcellular and biological macromolecule level, when we get clear down there, is actually caused by an interdigitation or a sliding together of the thick and the thin myofilaments. And that's what causes the whole thing to happen. Does that make sense to you? Now, there's a lot of details that we're leaving out of the story, but nonetheless, that's the essence of what occurs. A sliding together or interdigitation of thick and thin myofilaments. Any questions about that? Bryce?
So when you lift different weights and stuff, so you don't just send something flying off in the air, do they just go in a little bit for some and then all the way for the rest?
This is a good point. On a cellular basis, a muscle cell either contracts or it doesn't. It's an on or off thing. It's all or none on a one-cell basis. But you know that a given skeletal muscle like the biceps brachii is made up of thousands and thousands and thousands of skeletal muscle cells within its belly. So to get varying forces of contraction, we can contract just a few of those skeletal muscle cells, or if we're lifting something a little heavier, we can contract more. Or finally, we reach the dumbbell out at the end of the rack that is so big that that's as far as I'm going to go today. Maybe in this lifetime, that's as far as I'm going to go. You know, I see all these other great big guys that are handling all the rest of those, but that's as far as I'm going to. When you reach, you know, the maximum strength of contraction that you can produce, basically what's occurring at that point is you're recruiting all of the muscle cells that are in that muscle and trying to get them all to contract at the same time. And when they all do, that's as far as you're going to go strength-wise on that contraction of that particular muscle. So on a cell-by-cell basis, it's all or none. But to get varying force of contraction, we can contract more or fewer cells within a given muscle. Does that make sense, Bryce?
Yes, but every time that you contract a muscle, do the same muscle cells contract at first, or does it vary?
Now, that's a good question. In most cases, if you just want a very weak amount of contraction, it's going to be certain cells that contract. Let's go to a word. I want to define a word for you. Let's go to the overhead for just a second. The term motor unit is one motor neuron plus all of the muscle cells that it controls. Now, motor units are of various sizes. Some motor units only have a few muscle cells in them, and some of them, when we say all, some of them actually have several hundred muscle cells. One neuron controlling a few muscle cells, or one neuron controlling several hundred muscle cells. A given muscle, Bryce, is going to have lots of motor units, and it's going to have motor units of varying sizes within it. So if we just need a little bit of a contraction, we're going to activate motor units where the neuron only controls just a few muscle cells, and we get a very weak contraction out of that. Now, all of those individual muscle cells are contracting as much as they can contract, but the total strength or force of contraction developed by just a few muscle cells is not very big on the Richter scale. You understand what I'm saying? If we need to lift a heavier weight, we're going to involve more motor units and maybe involve several thousand muscle cells. And finally, we get up to the maximum strength of contraction that we can produce. Susan?
So if we want to do, what I'm thinking is how many muscles, if we want fine motor skills as opposed to gross motor skills, we're talking about units, not necessarily muscle cells?
We're actually talking about motor units. In general, if you follow this concept and think about it a little bit, we're actually going to have more finite control over those muscles where the average size of the motor unit is relatively small. Because if we get a big motor unit, if we've got a muscle that has mostly pretty good sized motor units within it, you know, you're going to contract one more motor unit, but that motor unit has several hundred muscle cells in it. Whereas if you need just a little tiny bit more contraction, if you can contract a motor unit that only has a few muscle cells in it, then you can get just a little bit more of force of contraction. Does that make sense?
Yeah.
So it turns out that we do have muscles in our body over which we have more precise control than certain other muscles, like the muscles that move our eyeballs around. We have extremely fine control over those muscles. The motor units within those muscles tend to be relatively small in size. Okay. Now, the muscles aren't very big either, but it doesn't have anything to do with the point that I'm trying to make. So that you can look from one side of a printed letter on a page to the other side of that same printed letter. You know, you can examine this side of the period's kind of fuzzy, and that side of the period's got nice clear print. You know, did a good job over there. And some of the muscles that are, say, in the backs of our thighs, and our gluteals and our hamstring muscles, very big, strong muscles, but we don't have nearly as precise a control. For example, if I said, okay, y'all, I want you to get up, and I want you to sit back down to within 1/32 of an inch of your chair seats. And I don't want anybody, a 16th, and I don't want anybody touching. And the reality is, you know, we'd be kind of hovering up and down. Oops, I touched. Nope. No, you can slide the whole textbook under this rear end right here, you see. So we don't have real precise control over some muscles. Other muscles we have precise control. And some of them seems to be developed to some degree. You know that I have better motor skills with my right hand because I'm right-handed, you know. When I try to write with my left hand, I'm not any good at all. Now, you can get better But I don't know if I'll ever get, you know, if this one got cut off or something, you know, I'm not sure you'd ever be able to read anything I'd know what it said, but I'm not sure you'd be able to read it. Any other questions? Let's take a look at a graphic that summarizes the levels of hierarchy that we just talked about in muscle microstructure. Remember that a muscle is at the organ level in the 10 levels of 10 levels of organization we talked about in the human body. The only thing above that would be system. So muscle is an organ. The cells within that organ are called muscle cells. They can also be called myocytes. They can be called myofibers. They can be called muscle fibers. All four of these terms are synonymous. Muscle cell, myocyte, myofiber, muscle fiber. And remember that a myofibril is a specialized contractile organelle within a muscle cell. So it's a contractile organelle. Now the muscle cells have all of the other regular organelles, but they have these special contractile organelles. Finally, if we look inside of a myofibril, we get down to the myofilament level where we see the thick myofilaments and the thin myofilaments that are actually down at the biological macromolecule level of organization because they are proteins. They're contractile proteins. Does that make sense to everybody? That just kind of reviews what we just went through. Let's look at the next graphic, which shows us the ultrastructure of a myofibril. And we talked about the A band being the stack of thick myofilaments, and it does include the overlapping ends of some of the thin ones as well because they do overlap a bit. The I band, the lighter staining band, is actually the space in between two adjacent A bands. So I want you to remember that an A band is not just the thick ones and an I band is not just the thin ones. But if you go back and take a look at the drawing that we made a little bit ago, if you copied that down, you'll notice that what we call an A band has thick ones primarily, but at the ends it's got some thin ones. Let's go back and look at that one more time. There's a couple of things I want to show you. Let's go back to that overhead camera. I'll just draw some 1, 2, 3, 4. Say these are thick myofilaments, and these are another set of thick ones with the thin ones overlapping a little bit like this and this. And then, of course, over here would be the same thing going that direction, and over here would be the same thing going this direction. Can you take a look at this and see why, if we took a look at the with an electron microscope and could actually see this, can you see a reason why the central area of each A band, when I say central area, I mean from here to here and from here to here, that central area of these A bands is going to be a little bit lighter staining than the two ends. Can you see why? Because out here at the end, we've got the overlapping thick, thin, thick, thin, thick, thin. But in the central area, it's just thick, 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 and thick. And actually, histologists will give we talked about this being the I band and this being the A band in here. But this central part of the A band, they'll actually call that the H band because it's a little lighter stain. I don't know what the H stands for, actually. And they actually have a name for this line that's caused by these cross-linking proteins and this line that's caused by this set of cross-linking proteins as well. So there's a lot of other particular landmarks down at the microhistological level here that we're not going to talk about. Main thing I wanted to get across to you is that the contraction actually occurs by the sliding together of these thick and thin myofilaments, which actually shortens the organelle that we call a myofibril, and then the cell itself is shortened, and then when a bunch of muscle cells shorten, we say the muscle contracts. Adam?
So when that myofilament contracts, does the I band shrink?
The I band gets narrower and narrower, and finally, when the thick myofilaments come right up against that cross-linking protein on the thin ones, it disappears. In a fully contracted muscle cell, the I band ceases to exist. The H band ceases to exist as well because everything slides together. Now, to get a muscle cell, a skeletal muscle cell to contract, we have to send a nervous impulse to that muscle cell. A given motor neuron typically supplies a bunch of muscle cells. Remember the motor unit concept that we talked about a bit ago. So we have to have the impulse go down. Skeletal muscle cells do not have inherent rhythmicity. They do not contract on their own without receiving a motor impulse telling them to do so. Now that is not true of cardiac muscle cells. They have inherent rhythmicity. We can speed them up or slow them down by nervous system influences, but they do not require nervous impulses to contract. And some smooth muscle cells do not require nervous impulses in order to contract. They also have, some of them also have inherent rhythmicity. But skeletal muscle cells must have a nerve supply. If we disrupt the nerve supply, that muscle will not contract again unless we stimulate it with exogenous stimulation like an electrical stimulus. So that's one of the reasons why severed nerves are so critical and so debilitating, because that whatever muscles that particular nerve would have supplied, those muscles have lost the ability to contract. Bryce?
Is it possible to sew the nerves back together like a muscle or your skin? And
You can. And you know these signs that you see along the side of the road that say, call blue stakes before you dig, you know? Before you go rent your backhoe and dig this trench right here, you're supposed to call somebody because there's probably a buried cable there or maybe a gas line or something like that. Well, if you imagine a nerve actually being a bundle of axons and or dendrites, we've got thousands and thousands and thousands of little nerve cell processes in this. If we disrupt that, yes, we can sew it back together, but the chances of all of those making the right connection is not good. And the part beyond where we severed typically will die back, and even though these axons can regenerate down into the part that dies away, there's connective tissue scarring that occurs that may prevent that. There's all kinds of problems, and it occurs at a very slow rate. Nerves regenerate in the manner that I'm talking about, Bryce, at the rate of about 1 centimeter a month. So let's say we severed, you know, a nerve clear up here. Maybe we sever my ulnar nerve right up here, and it supplies certain muscles down here in my hand. Okay, you can imagine how many centimeters there are between where we're severing it at this location and there are down here in the hand, and say it's going to be that many months before we're going to know if it regenerated at all, and if there's connective tissue ingrowth with scarring, even that may not occur. So it's a long-term wait and see kind of thing.
okay.
Certainly, when nerves are severed, major nerves are severed, the surgeon will stick the ends back together and suture them up. There's connective tissue ensheathment around them in an attempt to get as much of that happening as possible. Because if you leave them separated, then nothing's going to happen positive. So that's a good point. Now, we got to have a nervous impulse get to the skeletal muscle. When it gets to the skeletal muscle, does anybody know in general what happens? So the impulse gets to the skeletal muscle, and impulses don't go up and say, hello, would you please contract? What do they actually do when they get there? Does anybody know?
Stimulate it.
They stimulate it. How do they do that? Well, let's go to the overhead for just a second. We'll just write contraction up here. So we got the nervous impulse. We got to have that. What it actually causes to happen in the muscle cell is the muscle cell itself has an impulse. There's actually, it has an impulse, a movement, we'll talk about this a little bit in a future session, a movement of sodium, potassium ions, very similar to what causes what we call the nervous impulse within the neuron. So we have a muscle cell impulse, is the way I'm going to put it. I'll put quotes around it. So we have the depolarization, repolarization phenomenon within the muscle cell itself. That causes the release of calcium ions. And these calcium ions are actually released from the smooth endoplasmic reticulum. I'll just write SER, smooth endoplasmic reticulum. So calcium ions are released from the smooth endoplasmic reticulum. These calcium ions then attach to certain proteins on the thin myofilaments. And when they attach to these thin myofilaments, they cause some conformational or shape changes on those thin myofilaments, which actually uncover some binding sites. Now, let me make it real simple here. We cause a shape change, and we cause the thick and thin myofilaments to be physically attracted to each other in an electrostatic manner. So by causing the shape change, that initiates the interdigitation. Okay? There's a whole lot of details in between. When you take a course in physiology, they'll go through this. But the fifth thing that I want to put up here is, we'll just put thick and thin slide together. The thick and thin myofilaments slide together, interdigitate. That, in a nutshell, is basically the kinds of things that's happening within the contraction process within a given muscle cell. Let's look at a graphic that has these things actually a little bit neater, perhaps, than I wrote them out here. Physiology of contraction. We said the nervous impulse causes a muscle impulse. That muscle impulse releases calcium ions from the smooth endoplasmic reticulum. SER, smooth endoplasmic reticulum. Calcium binds to the thin myofilaments and causes shape change in one of the proteins that are there. And that shape change then causes the thick and thin ones to slide together or interdigitate. Now, ATP is required to unhook those thin and thick myofilaments and release the calcium ions back to the smooth endoplasmic reticulum. So energy in the form of ATP is required. But it's actually kind of required at the end of the process. By unhooking the thin and thick myofilaments, that's like resetting the mouse trap. After you've caught a mouse, you can use the same trap again, reset it. And so you only have to put energy into it. Every time a mouse gets caught, you only have to put energy into it once, because taking that mouse out and resetting for the next one are all the same thing. And that's what happens here. By using the ATP at the end to allow the thick and thin things to slide back apart. Now, they don't do that actively. They have to get pulled by gravitational or other muscles contracting to physically pull them. But to basically stop the contractile process itself, that does require ATP. And you will recall that when a person dies, and after they've been dead for a period, it depends on what the temperature is and some other factors, but after a person has been dead for a certain period of time, they get very stiff, don't they? That's one of the reasons why dead bodies are sometimes called stiffs, because they get stiff. Anybody know the name of that phenomenon, Adam?
Is that rigor mortis?
Rigor mortis. Rigor mortis, it's called. And what's actually happening is muscles are contracting, get contracted there. The contractile process occurs, and then the thick and thin myofilaments can't unhook, and so bingo, we have that stiffness that occurs. Of course, that rigor mortis disappears after a few hours, again, depending on temperature and some other sorts of things, when the chemicals begin to degrade and the breakdown of the tissues starts to occur. All right, let's look at a graphic that summarizes what we meant by motor unit. We've talked about this a while ago. We said it's a group of skeletal muscle cells innervated by one motor neuron. Large motor units have hundreds of skeletal muscle cells in them, and the small motor units may contain only a few muscle cells. Now, does anybody have any questions about that general view of contraction? I know we kind of blew through that kind of quick. I don't want you to understand detail. I want you to get the big picture. Seth?
Yeah, when the muscle like cramps up and you lose conscious control over it, what happens there?
You mean like one of those situations where you're laying in bed minding your own business and all of a sudden one of those muscles in the arch of your foot just goes crazy on you? Does that everybody here had that happen?
Yes.
Or maybe, you know, you're laying there and the muscles in your calf just suddenly clamp down. And you're kind of at their mercy there for a little bit, you know, because there's just not a whole lot you can do. There's several things that can be involved in a cramping process. It can be an imbalance of sodium-potassium. Sodium-potassium levels can be off a little bit. When you get extreme fatigue, sometimes the pH, when there's a lot of lactic acid that's produced, sometimes the pH changes occur down in the muscle cells to a degree where this contractile process will be initiated due to pH changes rather than nervous impulse coming down. And there's a couple other things. Calcium levels can also be involved in that too. So there's several things that can happen to cause that cramping. Best thing you can do is just try not to think about it and wait it out. That's the bottom line. At least it's what's worked for me. Bryce?
Is that the same thing with stomach cramps when you start exercising if you try to go too quick?
Not necessarily. Now, it depends on what you mean by cramps. You know, if I exercise too soon after, when I've got a real full stomach, for example, I don't feel like going out and playing a game of you know, touch football, simply because having a bunch of stuff sloshing around in there tends to make me a little bit nauseous. Now, is that what you're talking about with stomach cramps or not?
Like if you go out running and then it just kind of hurts
Oh,
and pulls you down.
the stitch that you get here in the side from, especially, you know, if it's been more than a year since I've gone out for my annual run. Is that what we're...
That's the one.
That's what we're talking about. So I go out for my annual jog and I get this little pain over here in the side. You know, I've read several different theories on that. And the spleen has been involved in one situation, you know, but I get them on the right side. Spleen's over here last time I checked. I've heard that there's some liver things. Has anybody else heard any theories on the pain in the side that you get from running? A lot of times, you know, if I can tough it out and run through it, it'll quit after a while, you know. And then and then maybe I don't get it the next time. I don't get it every time I go. Just every time I go run. So. Any other questions? But you know, it's a good question. I've kind of sidestepped it because I've read different things and I'm not sure what the answer is.
Okay.
Last time when we were talking in a previous session and introduced the muscular system, we talked about several items that can be documented on a particular muscle. I want to look at a graphic that actually summarizes those. I don't think we had this graphic last time. So if we're talking about a description of a particular skeletal muscle, just to review what we said last time, we have the name of that muscle. The proximal attachment, or less movable end of the muscle, is called the origin. The insertion is the distal attachment if we're in a limb, or the more movable attachment. The action, remember, is what the muscle attempts to do when it contracts, the potential motion that its contraction evokes. The innervation over here is the nerve supply. The blood supply means, hey, what branches of what arteries supply that blood to that particular muscle. And the shape is just, well, what shape does the muscle have? Some muscles have quite distinctive shapes. And there's a lot of muscles that have more or less what we call a fusiform shape, a little fatter in the middle, a little skinnier at the ends, and we just call that fusiform. And then what does it lie in front of or behind or between? Where is it located? That's what we mean by the relationships here. What's it physically related to? So those are some of the kinds of things that we could know about an individual muscle. And obviously in this class, we don't have time to talk about individual muscles that much per se, but we can talk about groups of muscles a bit. And I want you to think of your whole body for a second, and I want you to logically and geographically divide the muscles of your body up into certain number of groups, and how would you subdivide them? What would you say would be a logical way to do that on a regional basis? Eva?
Probably the same way we subdivide some of the bones into major parts.
We could do
rather
it kind
than
of in a similar way that we did bones, couldn't we? So let's see, doing that, invoking that logic then, and taking the muscles, how would you do that?
Maybe muscles of the superior limb, inferior limb, trunk, back, head.
Okay, we got muscles of the superior limb. We got muscles of the inferior limb. When we say trunk, we could probably divide those muscles up into muscles of the back, which you said, and then we could have muscles of the thorax maybe, muscles of the abdominal region. We got some muscles maybe of the neck and muscles of the head. Let's take a look at a graphic that summarizes what the anatomists do with the major groups of skeletal muscles, and I think you hit them pretty well, really. These are the 7 major groups of muscles, skeletal muscles in the body, and as Eva says, we can kind of divide those in a manner somewhat similar to what we did bones. The muscles of the head, neck, back, thorax, abdomen, including the pelvic region, the muscles of superior limb, of course there's left and right versions there, and muscles of the inferior limb. Then we could end up with these 7 groups. Now, within each of these areas, there are many, many subgroups. For example, we can take the muscles of the head and we can divide them up into, say, muscles of the eye that move the eyeball around. We've got the facial muscles, the ones that give us what we call facial expressions, frown, smile, purse your lips, open your eyes, close your eyes, that sort of stuff. We've got the muscles of mastication, chewing muscles. Everybody put your fingertips right here on the side of your cheek here, back at the corner of your jaw, okay? Now I want you to grit your teeth. Grit your teeth, and then relax. Grit, relax, clench, relax, clench, relax. Can you feel muscle swelling up under your fingertips? Mm-hmm. Mm-hmm. That muscle's called the masseter muscle, and it's one of the muscles of mastication. Big belly that occurs right back in here. Put your fingertips up here in your temporal regions, right on your temples. Okay, now clenching your teeth again and relax, clench and relax. Can you feel muscle contracting underneath your fingertips? Mm-hmm. That's temporal muscle that's contracting in that location. So those are some of the muscles of mastication. The muscles that move our face into different contorted, expressions, there's actually about 20 of those muscles. They're very, very tiny for the most part. Some of them are better developed, obviously, than others, but we got muscles of the face, and there's several other muscles within the head region as well. So a bunch of different kinds of muscles, groups of muscles, or subsets of muscles within this region of muscles that we call muscles of the head. Muscles of the neck. I got a collar on here, so you probably can't see, but if you turn your head to one side or the other, you can actually find a muscle here that comes down. Let's go over here to this little this model, and you can. This guy's got it right here on this. I don't know if the camera can catch this muscle right here. It's kind of small. Tell you what, I'll decapitate this guy and put him up here on the overhead. Let's get this on the overhead camera for just a second. Maybe if that relationship might be a bit better. This guy's asleep.
Sideways.
Wake back up. We'll come to class. Okay. Now we've got this muscle slanting right across here. It comes up and attaches, kind of behind the ear to the skull region. Comes down here and actually attaches down to the sternum, and it slants across. Now, you know that you've been able to see this muscle on your mom when she wasn't very happy with you, turning and twisting her head one way or the other. This is called the sternocleidomastoideus muscle, and when it contracts, when the two of them, there's a left version and a right version, when they contract together, of course, they twist our head to the left, or actually pull our head down, you know, to look down. But if just one of them contracts, it'll pull our head to one side or the other. So that's an example of one of the many muscles of the neck. There's a whole bunch of individually named muscles in that neck region. Put his head back on. You know that there are lots of muscles in the thoracic region. These muscles right here, the pectoralis major muscles, or down in the weight room, we just call them the what? The pecs. The pecs, you know, P-E-C-S or P-E-X, depending on how you spell it. But these guys, what exercise would I actually do if I wanted to develop bigger pectoral muscles? Eva?
Push-ups or bench press?
Push-up or bench press. Push-up or bench press, okay? Because this particular motion, the muscle belly lies here on the front. If the camera can come over to this muscle model here, this is the major pectoral muscle lying right here. And when it contracts, it's going to cause a protraction type movement of the superior limb, bringing the humerus forward, and the muscle will be exercised again by push-ups or the bench press type exercise. Trapeze artists, the people that spend the time on a high wire hanging from bars and so forth. Have you ever noticed they and competitive swimmers have this kind of wedge shape to their trunk? Shouldn't they be kind of small-waisted and get kind of broad up in the chest? And the reason that they have that particular shape is because one of the muscles of the back, again, trunk part muscle, but a muscle called the latissimus dorsi is actually very well developed in those folks. So that gives a person a very wedge-shaped appearance. So if you do a lot of pull-ups, for example, or chin-ups on a bar, you can develop this muscle that lies kind of underneath your superior limb, kind of along the side of your trunk in this region. So those just some examples of individual muscles in the trunk region. Here's another one that we need to talk about just a little bit, because we talk about it down in the weight room a little bit. The muscle's name is rectus abdominis muscle, and it has some tendinous inscriptions across its belly, such that when it's well developed, because we've been doing our sit-ups and our push away from the dinner tables, then we call this the what muscle? What's that commonly called down the weight room?
Six-pack.
Six-pack, because you can often see, you know, 6 swellings, 3 on this side, 3 over here as well, often called the six-pack. Although I am told that if you drink too many six-packs, you won't have much of a six-pack in that location. All right. I know it takes a while. Those are not great, but they're the best I can do off the moment. All right, let's take a look at the muscles of the superior limb for just a little bit. I want you to think about them on your own body from a regional standpoint. We actually have 6 groups of muscles in the superior limb. We have several muscles in the shoulder region. We call these shoulder and scapular muscles. And they're going to be involved in motions that occur primarily at the shoulder joint. We're going to have flexion and extension of the shoulder joint. We're going to have adduction and abduction of superior limbs. And we're going to have maybe some rotation at the shoulder joint. So these are muscles of the shoulder and scapula. Then if we come on down into the brachial region, there are 2 groups of muscles here. Anterior brachial muscles and posterior brachial muscles. Now, one of the major anterior brachial muscles is the biceps brachii muscle. And the major posterior brachial muscle behind the humerus is the triceps brachii muscle. So anterior and posterior brachial muscles. Then we go down to the antebrachium, and we also have 2 groups. Anterior antebrachial muscles, and there's actually 9 of them there. 9 of them. Posterior antebrachial muscles back here on the back side. The anterior antebrachial muscles tend to flex the carpal joint and the digital joints. The posterior brachial muscles tend to extend the carpal joint and digital joints. Then the 6th and last group of muscles within the superior limb are the muscles that are found intrinsically within the hand. There's actually 11 individual muscles in the hand. They're all real small. They got great big names, little teeny tiny muscles, but they're involved in some of the finer movements that the digits are able to make relative to each other, okay? These kinds of motions here. Let's look at a graphic that summarizes those groups of muscles in the superior limb then. We said 6 groups, and here they are. I don't think it's too important that you remember these numbers that are over here on this side, but I put them in there just to show you how many muscles are in that group. So on this first group here, muscles of the shoulder and scapula, there's actually 7 muscles in that group by name. Just to give you some of the names: deltoideus muscle, supraspinatus muscle, infraspinatus muscle, subscapularis muscle, teres major muscle, teres minor muscle, and so forth. Those are some examples. We move on down. Anterior muscles of the brachium, there's actually 3. Biceps brachii, brachialis, those sorts of muscles. Posterior muscles of the brachium, there's only 2. And then anterior muscles of the antebrachium, 9. Posterior muscles of the antebrachium, 9. Intrinsic muscles of the hand, I mentioned before, 11. There are 41 individual muscles in the free part of each superior limb. Again, I don't think it's important that you remember the numbers, but I think it's kind of interesting to total them up sometimes. If we go to an inferior limb, we can actually divide the muscles of the inferior limb up in a manner similar to what we did, except we have more groups. There's actually a total of 9 groups altogether in the inferior limb. And just to quickly go over those, but not belabor the point, there are actually 3 groups, if the camera can move down just a little bit. There's actually 3 groups of hip muscles. There's some posterior hip muscles and some medial hip muscles and some anterior muscles of the hip. And of course, those, when they contract, are involved in various motions of the hip joint. Then when we get down to the thigh region, there are 3 groups of thigh muscles. There are anterior thigh muscles on the front. There are medial thigh muscles on the inside. And there are a group of posterior thigh muscles. Anybody know what we call the posterior thigh muscles? What's the term, Adam?
The hamstrings?
Hamstrings. Hamstrings, okay. So we got 3 groups of thigh muscles. Then when we move on down to the crus, down here, I want you to reach down and I want you to feel below your knee, above your ankle someplace, and I kind of want you to be on the medial side. And feel it feels pretty hard and bony there, right, on the medial side? Yeah. Well, that's because that's the tibia right there. On the lateral side of that same region, though, it feels kind of soft because out there we've got a group of craniolateral muscles of the crus. Right, did I say craniolateral? Anterolateral. A little veterinary medicine sneaks back in every once in a while. Anterolateral muscles of the crus. And those muscles, when they contract, tend to flex the tarsal joint and extend the digital joints down in the foot. And then, of course, you're familiar with the posterior muscles of the crus, the ones in your calf of your leg. Those tend to extend the tarsal joint, and we'd contract those to go up on the tips of our toes, for example, or they flex, others within that group flex the digital muscles down in the joints, digital joints. So those are the 1, 2, 3, 4, 5, 6, 7, 8, 9 groups of muscles in the inferior limb. I just wanted to show you kind of how those were divided. Let's look at a graphic that shows certain clinical conditions associated with skeletal muscles. This graphic then summarizes what we just said. 9 different groups of muscles in the inferior limb. There are actually 2 muscles that are anterior hip muscles, 4 that are posterior and lateral, and a total of 6 that are medial muscles of the hip. Then we have 2 anterior muscles of the thigh, 3 posterior muscles of the thigh, and a total of 6 medial muscles of the thigh. Down within the part of the limb that we call the leg, anterolateral muscles of the crus, 6 different individual muscles. Posterior muscles of the crus, there's 7. And then there are 12 intrinsic muscles within the foot for a total of 48. Again, those numbers are not important to remember. I just wanted to see what those numbers were. Let's cut to another graphic now that summarizes some of the clinical conditions found in various skeletal muscles. When we say atrophy, we've talked about this a bit before, but atrophy is a decrease in size or functionality related to disuse or lack of nerve supply or sometimes injury or disease. The term atrophy is not just used in conjunction with skeletal muscles. Any organ can undergo atrophy. It gets smaller and less functional is what that means. Hypertrophy, on the other hand, implies the opposite situation where an organ gets larger. Now, hypertrophy can occur due to an increase in number of cells in some organs. In skeletal muscles, we said hypertrophy, when it occurs, though, does not occur due to cellular increase, but simply the size of individual cells getting larger. Rigor mortis, the stiffness in death that we talked about before in association with skeletal muscles, again is due to a loss of ATP production because the cells are dead, so the relaxation process cannot occur. When we say that we pull a muscle, we are damaging some of the soft tissue structure of it. We may pull it so hard that some of the muscle fibers are damaged or some of the connective tissue within it is disrupted. Paralysis means a muscle cannot contract, typically because of loss of nerve supply. And Seth, I believe, asked a question about cramps. Cramps occur, again, in relation to sodium-potassium imbalances. They can occur due to certain calcium levels not being exactly right or to severe pH changes related to lactic acid buildup. Do you have any other questions? Okay, we'll see you next time.